good afternoon, and thank you for joining us today. Dan, if you can go that next slide with the title on it. My name is Mark Seipert, Healthcare Solutions Advisor for the Wisconsin School of Business and our Center for Professional and Executive Development, also known as CPED. I'm excited to have you with us as we hear from Dan Sachs of the Wisconsin School of Business and our featured panelists. But before we start, I'd like to share a few words about CPED. So Dan, if you can go to that next. For those not familiar with our center, we've been around for nearly 80 years, partnering globally with organizations to aid in the development of their talent. We provide programming, coaching, and consulting to elevate individuals and teams around business and financial acumen, leadership, continuous improvement, strategy, and numerous other areas. This is done via open enrollment programs in Madison, but more often now in customized sessions brought on site to our partner organizations. Recently, we've made a strategic shift to focus on core industry verticals, which one of those being healthcare, which I'm proud to lead. We currently partner with WHA in facilitating a healthcare leadership academy and look forward to continuing to provide thought leadership like today's webinar and programming critical to the continued elevation and retention of key talent in your organizations moving forward. So to learn more about our center, please visit our website at www.uwcped.org. So if you could advance one more, Dan, just some housekeeping. If you have questions you'd like to ask during today's webinar, you can submit those using either the chat or Q&A buttons on the Zoom webinar screen. We'll pose those questions towards the end of the webinar in our Q&A time. And also wanted to mention that today's webinar is being recorded, and a link to the recording will be made available within the next few days. So now I will turn it over to Dan Sachs. Dan is an associate professor in the Risk and Insurance program at the Wisconsin School of Business. Dan will be facilitating the conversation with our esteemed guests today. Dan, I'll hand it over to you.
Thank you, Mark, and thank you all for joining us. Before we get to our panelists, I want to give you some background on healthcare in the United States to better appreciate this conversation. The first thing you need to know about healthcare in the United States is that we spend a lot of money on it, $4.3 trillion. Trillion is kind of a hard number for me to wrap my head around. So the way that I think about it is, first, that works out to $13,000 per American, not per American who goes to the hospital or per American who uses any healthcare. It's $13,000 on average for each of us. Healthcare spending also works out to 30% of the median worker's annual income. That's a lot of money. Another way to think about it is that the US spends more on healthcare than any other country, more in total, more per person, and more as a percent of our income. It's more actually that we spend on healthcare than Germany spends on everything. 4.3 trillion is bigger than the GDP of Germany. Now you might think, I didn't pay $13,000 per healthcare last year. Where did this number come from? Well, we pay for our healthcare in a bunch of different ways. Some of them are probably obvious to you, like co-pays and deductibles and your premium contributions. But others are less obvious. Employers pay for their employees' health care, and to finance those benefits, employers have to offer lower salaries than they would if healthcare spending were lower. So we pay for high healthcare spending with lower salaries. And another way we pay for it is through the government. Federal government's the biggest purchaser of healthcare in this country, and of course we have to pay for that government spending with higher taxes. So what does that exceptional healthcare spending get us? Well, not an exceptional healthcare system. Many people find healthcare unaffordable when they need it. Employers and governments alike also struggle to pay for healthcare financing. When you have to see a doctor or get treatment, wait times are often frustratingly long, and then when you get in the door, the visit is disappointingly short. And it's not like providers are any happier either. We hear increasingly that doctors are reporting burnout and considering leaving the profession. How did we get here? Well, I want to contrast for you two models of the healthcare system. One model, which I'll call the traditional model, bears some responsibility for the current state of affairs. That traditional model is based on fee-for-service. Under fee-for-service, providers are paid for the services that they provide. If you see a doctor, the doctor gets paid. If you need surgery, the surgeon gets a payment and the hospital gets a payment. So there's a natural, strong incentive to do more. But it's very transactional. We end up paying for transactions and for doing things. An alternative approach is what we'll call the value-based approach. By value here, we mean how much health are we getting for our patients and for the population, divided by how much we spend on providing that health care. A value-based approach emphasizes measuring health and promoting health. And instead of paying for individual transactions, we want to pay for health. I'm excited today to hear from 3 experts in this area who've led the transformation towards value-based care. Krista Hoglund is Chief Executive Officer of Security Health Plan. She represents Plan's perspectives on promoting value. Jason Sansone is President of Orthopedic and Spine Centers of Wisconsin, and he's led transformation towards value-based orthopedic care. And Adam Myers is Senior Vice President and Clinical Transformation Officer, Blue Cross Blue Shield Association. He's led efforts towards value-based care and transformation, both from health insurers and from several health systems. So now I'm going to turn it over to the panelists. And to start, before we move on to kind of the value-based experience, I'd love to hear a little bit about experience in the status quo fee-for-service world. So Jason, maybe you can describe, to kick us off, what your experience was like as a surgeon in a fee-for-service environment.
Sure thing, yeah, and thanks, Dan, for the intro. That was really well stated and encapsulated where we're at as a country right now. You know, I think the other key point too, even to put a bow on that, is that our country's GDP is somewhere on the order of $20 trillion. And so if you think about it that way, we're spending 20% of our country's GDP on healthcare, which is an astounding amount. So how is it to work in a fee-for-service environment? There are a couple thoughts that come to mind, the least of which is it can often be exhausting. There's an emphasis on volume, and when you're asked how much is enough, the answer is always more. It incentivizes doing things in high reimbursement areas. It incentivizes interaction even in your head about how does it intersect between doing what is right and doing what is more productive, whether that be for the organization or for you as an individual provider. And I make no mistake about it, I'm not insinuating that people are innately nefarious, but even on a subconscious level, when these incentives aren't aligned correctly, behavior follows the incentive, right? Show me the incentive, I'll show you the behavior. And so, that has been the history of the last 40 years or so, 50 years or so in our country as it relates to fee-for-service, really since Medicare kind of got up and running. So here we are now.
Yeah, and Krista or Adam, would you like to add anything to that?
Go ahead, Adam.
I was going to double down a little bit on a little bit about what was just said. If you think about it, there is a phenomenon that what gets paid for tends to occur, and what gets paid for more liberally or tends to occur more often. And when volume or doing stuff is what gets paid for, that's what occurs. And we have seen significant volumes of activity being done, and we don't necessarily have a health system, unlike many of the other health systems in the world, that focus on moving upstream toward prevention instead of treatment of disease. Other systems focus, in addition to that, on moving upstream toward prevention. They focus more on the social determinants of health, the things that happen outside of the traditional healthcare system that are really felt to contribute to about 80% of the outcomes that people have. And so I think this different approach, they also tend to pay more based on outcomes rather than volumes. And so I think that's part of why we are where we are. And it is a bit of a hamster wheel, so to speak, to be on as a clinician, where you just feel like you're just running, and you don't get the opportunity to build relationships with people. So, Krista?
Yeah, so, I would agree with everything that's been said, and particularly, right, people aren't, by design, nefarious, right? It's just, when you get paid to do more, you're going to do more. And instead of focusing on what is exactly right for that individual patient in front of you, you might have that bias towards, well, it, it could be any number of things. So I'm just gonna, sort of check every box, right? Do every test, rather than, really stepping back and reflecting on what's right for that individual, and what's the right amount of service for that person. And then also thinking about, health, right? Instead of, illness, we're actually paying for people when they're sick. And so, how does Jason get paid if he's actually, thinking more about wellness and managing population than if he's only thinking about, how to do surgeries? And so, that gets into the, how do we start to frame up to think differently about it, as opposed to, right, we're just going to pay him more for every surgery that he does.
Right. So in kind of the status quo world, we have strong incentives for volume and service. What does the alternative look like? Maybe Adam, you can tell us different models that you've pioneered.
Yeah, I'll come at this from a couple of different perspectives. One, I'm a primary care physician. Two, been a health system leader at multiple health systems, Methodist Health System in Texas, Cleveland Clinic, Texas Health Resources, had significant roles at those organizations. And now I'm coming to an addition from the payer perspective. For the last 20 months or so, I've been at Blue Cross Blue Shield at a national level as the senior clinician, serving 115 million Americans. That's 1 in 3 Americans are insured by the Blues. So that's pretty material scale, and it's given me a view of this reality and a little bit about what could change and what I believe needs to change. I will mention, though, just for clarity, I am transitioning out of that role with the Blues and moving into what I call free agency, and secondary to a reorganization at the Blues, but it's all good. But so to answer your question, what does the alternative look like? If transactional isn't what we really want, if episodic care is not what we really want, then changing from a fee-for-service model that promotes those things to a more longitudinal relational model where outcomes matter more and where the relationship in a long-term sense is rewarded is what it's about. And when I was at Cleveland Clinic, I had a large swath of the organization in my reporting structure, and just the reality that you described, Jeff, was very real there. I mean, we had primary care physicians that felt like they were just feeding the beast of specialty care, and they were seeing a new patient every 15 minutes and really didn't have a relationship with anyone. It's patently unrewarding as a clinician. It's not rewarding for patients, and the outcomes really aren't great from that. And realizing that what gets paid for tend to occur, we chose to change our payment paradigm. We chose to move toward prospective payments, and we're going to get toward a little bit about that in a minute. And that change toward a capitated model for primary care was really essential to change the care model. And that's a model in which you get paid upfront per patient per month, a negotiated amount. And what happens then is that you can change to where you now, not every activity that you do has to be directly compensable. You don't have to think, am I going to get paid for this activity? You're already getting paid up front, and you can focus on what do we need to do that will be impactful for people. So it enabled us to really build out the teams. We had team-based primary care where behavioral health social workers were embedded in the primary care practice. Pharmacists were embedded in the primary care practice, where the practice would stop seeing patients periodically to say not just who's on our schedule, but who's on our panels that we need to reach out to that's not coming in to see us, that needs our help, and how can we reach out to them proactively. So it's a completely different model of care focused on that relationship. And I tell you, what we found was it was so much more filled with joy for the clinicians. They could build relationships and actually practice medicine rather than just churn. Patients loved it because they had longer appointments, better access, lots of greater variation. This enabled us to do virtual care before virtual care reimbursement went up. This enabled us to focus on doing asynchronous care through messaging and things like that. Actual house calls were enabled through this because we didn't have to worry about whether or not they were, again, being paid for directly. So the experience was much better for patients, and the outcomes followed that. And lo and behold, the spend became more appropriate as well. So it was better outcomes all around.
Yeah, so I'll maybe jump in here. I have a little bit of a different lens, partly by training, I'm an actuary, right? So I think about this a little bit differently. And then also most of my career has been in an integrated health system, as a leader on the plan side, but also sort of living in, whatever you do on the plan side does have an impact in care delivery, and understanding what that impact is. So, the sort of idealized, way that I think this should work is really collaboration, plan provider collaboration. Both entities are important. Both entities bring something to the table, but keeping the patient right in the middle, right? The patient as the center. And whether that's, taking care of them because they're ill or, making sure that they, stay healthy, it doesn't matter, but that perspective is so important. And when you can set a value-based care arrangement around that, which we're going to get into some details, I know in a bit, I feel like you can get to that alignment and remove, some of what otherwise might feel like, sort of, clashing perspectives around how to best care. So, some examples of that, everybody's favorite that works is prior authorizations, right? That's a common pain point between provider and plan. If you're really working in alignment, you work together to develop care pathways that you're both agree to. And so it's not, well, the plan said I have to do this thing, otherwise they're going to deny it. And it's not, the provider is doing this thing that we don't think is appropriate. You just completely remove that from the conversation because there's alignment on how to best care for a patient with this condition or disease or what have you. And so I think that thinking from that perspective and then designing sort of reimbursement with that in mind is really kind of the best way to get the right care for those patients at the right time.
And I can add to, clearly I agree with what Adam and Krista have said. I think the way that I conceptualize this in my head is I'm trying to think through how to create these value-based, really, I use this word a lot now, ecosystem. Is if you think of the patient in the middle and then this triad that surrounds them, right? It's the physician assistant, or the provider. Then you have the insurance arm, and then you have the hospital/health system, right? And each of those three players, stakeholders, need to be able to keep the patient in the middle. And so it really comes down to how do you design ecosystems where truly the incentives are aligned. And I think always keeping in mind two additional things, which are, given my science background, I always tend to make analogies. So, Ohm's law, right? Electricity follows the path of least resistance. Well, so do humans. And so can you create, not only in these standardized care pathways, but can you remove the barriers to simply being able to follow the path of least resistance, which is value-based and aligned with the incentives of that system? Because oftentimes we create these systems that violate the second law of thermodynamics, which, again, forgive me, I'm a science guy, which is that entropy is always increasing, right? And we've created this overly complex system in America as far as who you need to contact and how do you get this approved and how you, right? And so keeping an eye on the fact that entropy is always increasing. And in fact, we need to get to a more orderly way of going about the complexities of managing patients. And when you're designing these alternative systems, those two things need to come to the forefront. But I think, more and more people are beginning to wake up to the fact that something needs to be done I think the fact that the healthcare system in this country is broken is now kind of accepted as fact. And so really it comes down to who's going to be at the forefront and forward thinking about how to redesign all of these things. And you know, you're hearing from the hospital health system perspective, from the insurance perspective, and from the provider perspective today. And we all have things to add to that.
Great. So I want to remind and reassure our audience that we're going to answer your questions at the end. So, you know, if questions come up, please drop them into chat and we'll circle back to them. So one thing that I'm hearing from the panelists is, like, on the one hand, it sounds like a great patient and provider experience. On the other hand, there's a lot of challenges in getting the financing to work. When you're paid on a fee-for-service basis, it's pretty clear where the money's coming from, but in the sort of value-based arrangements, it's less clear. So could you talk us through kind of what alternative contracts between payers and providers have looked like or might look like in the future? I guess we'll start with Adam.
Sure, there's a lot of approaches that can be here. There's, you know, traditional fee-for-service with no incentive for outcomes at all, which is sort of where it all started. There are payment models that include, you know, some upside bonus for doing well, having better outcomes or certain activities that can promote better outcomes. Then there's overall risk-bearing contracts where if you have an extraordinary spend or don't have the outcomes that are desirable and agreed upon, that you actually lose money in the provision of care and have to maybe pay back some funds to the payer as providers of healthcare. And those are called downside risk payment programs. And then there's sort of what we call total cost of care or full risk sort of payment paradigms, where a certain amount and is budgeted per member that is being covered, and that amount is being paid on a periodic basis directly to the health entity that is chosen to accept responsibility for those outcomes. And that's it. There's no more sort of brought to bear. And if you are able to provide great care with great outcomes for less than that amount, then you keep the what's left. If you end up, you know, requiring that in order to get the outcomes that are needed and provide the care that you spend too much, that's kind of on you as well. And maybe that'll inform the next negotiation. So those are all a variety of different approaches to payment. And it's not just the payment negotiation that gets dicey. It's even thinking about you know, as a clinical leader within a health system that was making this transition, conversations like, if, you know, there's this thing called the relative value unit, which is a measure of productivity that is very standard in healthcare delivery, that says, you know, all of the activities that physicians do have been assigned a relative value unit. And relative value units, RVUs, worked RVUs, can be set, you know, there are certain targets set from a productivity standpoint by clinicians. If you depart from normal activities that don't have an RVU value, or you're not billing in that fee-for-service paradigm, then it's more difficult to monitor people's productivity. And I remember when I shifted toward a capitated model where a prospective payment model, I had the finance people at the organizations where I've been in this transition saying, how are we going to know the clinicians are productive when they're not dropping itemized bills anymore? And it's like, well, based on panel size and outcomes. And it, you know, they said, well, we're going to give you volume targets anyway. And I remember saying, I can tell you right now, I'm not going to meet the volume targets from an activity standpoint, but let's focus on these other things. And it's an interesting dialogue, and you move through it. In other words, to say, do we really want the volume or do we want outcomes? And how do we pay for the outcomes? But those are some of the different payment paradigms that can be negotiated in order to support different approaches. Krista, what are your thoughts?
Yeah, so as you were talking, I was thinking about a number of things, including, so, within my organization, we've been doing a full cap arrangement. So full capitation, as you described, kind of way on the end of, the kind of the most elaborate, risk shifting mechanism that you can really do between payer and provider. And we actually implemented that back in 2018. And it was a big sort of internal transition. And, I feel like we're still there, we're still figuring out how do you manage through it, because it is such a major change for how providers think. I still cringe, right, whenever there's a presentation where they talk about productivity, because I'm like, hey, we're already giving you all the money. You don't actually need to do anymore,
Exactly.
right? The focus needs to be around the right care. And I think that it's the, we want Jason to be fully productive doing surgeries, but we actually want him to be doing surgeries on the patients that truly need surgery, that are most likely to get the best possible outcomes. And we want other people that, might have, knee pain, hip pain, whatever, going through a different sort of track to actually have the most effective outcomes. But I think, the idea of you get a chunk of money, you're going to get that money regardless of how many services are provided. Now you have to think about what is the most effective way to internally allocate that money. And I think it actually can be a real innovation boost, potentially, right? Because you've got people thinking about how can we provide the best possible care, not having to worry about how we bill for it. Right? Like, what does this person actually need to have good outcomes? So what support services might actually make more sense? What partner, what vendor might be able to provide a wraparound supplementary service. So diabetes, I think, is a great example, right? Folks that have diabetes need a lot of additional support that you probably don't want your physicians to actually be giving them, so that your physicians can operate at top of license. But if you've got, different kinds of support mechanisms that you can use to help those patients get the outcomes, it's, more cost, and you're going to get a better outcome. So I really think that's another key kind of value-based care, is you get people thinking differently about best possible care, because it's not a requirement that they have to be able to bill and get reimbursed for it. So that's an important, I think, key to this.
I like what you said about, using the example of Jason about wanting him busy. It's if you think about it, under the fee-for-service model, a health system is really happen if Jason is doing a lot of different procedures and doing a lot of different surgery, and the outcomes are nice. Under a capitated or prospective payment model, whether Jason is busy doing surgery or not is not nearly as relevant, because what you're really wanting is a healthy population. And if Jason doing surgery is the best use of those funds in order to encourage a healthy population, then yeah, we want Jason doing surgery in that model. But if for an individual patient that's not the case, we don't want Jason doing surgery in that situation.
And I think to your point as well is a couple of things that you said resonate with me. So first, I think it's important as a way to level set. When you look at, for example, a payer's entire book of business as it relates to MSK, musculoskeletal care, right? That's a big portion of any payer's book of business as far as the expenditure there. It's about 25%-ish usually. And so if you think about it in that terms, we spend 5% of our country's GDP on musculoskeletal healthcare, which is just astounding. But about 80 to 90%, depending on how you cut it up, is related to all the care that doesn't occur in the surgical episode, right? And so you have the unnecessary ordering of MRIs, the lack of following standardized care pathways, the extended PT visits and injections that patients might have to go through in order to qualify for getting a knee replacement. And really, at the end of the day, from the provider perspective, a value-based care ecosystem allows me, for example, if I see a patient with knee pain who has horrible end-stage arthritis and can't walk very well, to say, okay, look, at the most conservative, most cost-effective treatment here is to do a total knee replacement. We don't have to send them through 3 months of PT and 2 injections requisitely so that we can get approval. We actually just will go to the operating room and fix it. Now, in a true value-based full risk model, which is what we're all speaking about, would like to ultimately get to, as we said, I can either be paid to do that surgery directly, or I can be paid via some type of incentive program for actually simply not operating on unnecessary people and saving healthcare spend dollars by utilizing other care pathways, right? So, and again, you have to always focus on the how do we align incentives, because for a provider, at the end of the day, if we can create the right system, we all providers can simply see patients and just do the right evidence-based treatment for them. And you don't have to think about what's this going to, cost me, or what am I going to get paid for this, that, the other thing. It's you, the patient, being able to look and have that one-on-one encounter in that relationship and be able to say, look, I think this is the best option for you, irrespective of what that means for my pocketbook, because regardless, there's a financial incentive for me to do the right thing.
Jason, I'm so glad you mentioned that point, because I think you could hear about some of these alternative payment models where like the health system or the providers are getting paid the same amount regardless of how much care they give. And yeah, that reduces incentives to do too much, but how do we know that providers will do enough? So one thing you're hinting at is sort of tying the payments to appropriate care. And
Right.
in general, I'd love to hear more from the panel about how we measure quality of care or patient outcomes or appropriate care, and how we make sure that the patients ultimately get it. Go ahead.
Let me loop back a little bit just to propose a slightly tweak to some of the value-based care arrangement or contracts that we've talked about so far. So there's perhaps an alternative way of doing that, which is to say, we're going to take a population of folks and we're going to pay providers, or we're going to budget a per member per month spend on a large group of diseases. So whether you want to do, again, let's just take the musculoskeletal because that's what I know. So all 26,000 ICD-10 codes that touch a musculoskeletal patient, and those are the diagnoses, 26,000 diagnoses codes. And so you can create contracts whereby here's your budgeted spend over the course of a year. As you perform procedures on those patients, or as you do billable events on those patients, you will be paid in that fee-for-service model. But understand that at the end of the year, we'll reconcile what you spent on a fee-for-service level to take care of that population. And if there's a delta, then you either get incentive payments that go perhaps 50% to the payer, 50% to the surgeons, and as an incentive, or if you overspend, that difference gets split as a reconciliation payment 50-50 as well. And so it allows you to still function in that whole concept of fee for service, but in the back of your head, that if you don't do surgery on somebody, it still in a way flows back to the stakeholders in the organization. And how does that flow back? Well, it can flow back as an incentive payment. It can flow back as program funding for something you want to pursue to innovate. It can flow back to patients via premium relief. It can flow back to patients via expanded services from the payer, right? So there's all different sorts of ways of doing it, where it's kind of this hybrid approach, ultimately as a value-based total risk contract, but that fee-for-service infrastructure can still be there, such that you're not in a situation where you're simply rationing care, where you're saying, well, I mean, I get paid either way, so I'm just, I'm going to come into work in flip-flops and work for an hour, and then I'm going to go home. And, that's obviously what you don't want either. But I think as you create those systems where the stakeholders see that the incentives aligned, it's often not about the bottom line dollar that matters. The portion of compensation that matters is actually the principle behind it. And if you can understand simply the principle, you typically aren't going to have even enough time or patience to want to go and bean count and figure out what the, you can simply go in and say, look, I know there's a reward for just simply doing the right thing. I don't know the exact reward, but it's there for doing the right thing.
Dan, an interesting thing that we saw, and I'm not sure, I imagine you did too, Krista, that during the pandemic, volumes dropped pretty dramatically. And for hospital systems, health systems, providers. And, that created, nearly an existential crisis for many different provider systems. And when providing care face-to-face was no longer possible, volumes of surgeries dropped, it was a big deal. The degree to which we were in prospective payment models, the degree to which we were in capitated models where we're getting paid up front, that actually served as a significant buffer to us, to the volume fluctuations, and made the financing work as a provider organization. Because, when volume dropped, we're like, okay, it's all right, we're still getting paid. How do we change the way we're caring for people rather than trying to force people into a model of care that'll get us paid?
Yeah, I would say that the most startling example for us that we spent a lot of time talking about, just that gets a little into, appropriate usage of care, along with your point, Adam, is we saw ER. We actually saw people utilize ER correctly, like for the first time ever. So ER volumes dropped significantly. People were truly only going to the ER for stuff that required emergency level services. So that was, I think that was an interesting learning. And they've not since gone back up, right? And people have gone back to the way they, but it was one of those that I hoped that we sort of had established a new sort of standard of care for what the ER is supposed to be for. But really interesting, in a pandemic, people self-selected to the actually appropriate utilization in many cases.
Yep.
But we also saw underutilization, and that was the point I wanted to actually make here as well. Is I think one of the myths about value-based care is that it's all about reducing utilization, and really the focus is right care, right time, right place. And very often we are just as focused on things that need to be done as we are on things that are being overutilized. And as a nation, we talk a lot about the waste. It's a huge number, and certainly there are many things where there's overutilization. But honestly, nobody wins in a scenario where people aren't getting needed preventive care or aren't having appropriate sort of chronic disease management, because ultimately those become much more costly if they're not either managed effectively or caught early. So again, another, kind of thing that we're experiencing from the pandemic and people not getting needed preventive care is we're seeing, they come in and, instead of early stage cancer, right, maybe they're a little further, and then all of a sudden the treatment is more costly. The risk, of them not having a positive outcome is higher. And so really, provider systems, again, and plans, I think, are more aligned than what people realize around, we actually do want people to get care. And medication adherence, again, is another great example. If people have a chronic disease and they're not taking their medications appropriately, it's more costly. So we want folks to be taking their medicine. And there's a lot of data and analytics, again, in a value-based arrangement, that are looking at who needs to get in for preventative care, what's our strategy for outreach. And it's usually coordinated between plan and provider to say, okay, who's going to do the outreach, who's going to make sure that we get these folks in and make sure that they get that needed preventive care as well.
I think to your point there, Krista, is another thing that is an unfortunate side effect of a fee-for-service model of care, which is that healthcare equity suffers. Because what's happened is that the things that aren't directly reimbursed in a fee-for-service model to providers, as we said, aren't done. And so a lot of those preventive care types of things have been outsourced to the private markets. And so, if you want to do weight loss, or if you want to be, do cardiovascular fitness or strength training, or, proactive diabetes management when you're at risk, nutritionist, all that kind of stuff, oftentimes those things are much more accessible in the markets outside of a healthcare system and outside of insurance, which then creates this gradient of only the people who pursue that have the money to purchase those services. And so, look, I'd love to be able to start a program whereby we can enroll patients who are just simply metabolically at risk for having all sorts of issues, the least of which are MSK issues. But then the question comes, well, how are we going to pay for that? And if it is simply a cash type of transaction, well, then that's not equitable. And so how do we create that environment? Because preventive care needs to be ultimately what's emphasized in the country, right? For everything.
Well, I think there's a lot of like really exciting developments here, but it also seems like kind of a major transition for a lot of healthcare organizations and plans and payers to both rethink their approach and also to rework their approach. So maybe you can talk through some of the challenges organizations face in pivoting towards more of a value-based approach.
Yeah, I think one of the challenges has to do with a couple of things. If we're thinking about paying more for outcomes, we have to stack hands, agree on what outcomes do we want? What does that mean? And how do we measure those things? There's not a lot of agreement necessarily about what health is, what degree of, even for something as simple as diabetic control, to seemingly simple to measure, there are different definitions by payer sometimes about what adequate control looks like or doesn't look like. And so I think there's a real opportunity for alignment of measures. There's a real opportunity of focusing on a balance of process measures, meaning how often are you doing certain activities for the patients that you serve, and a real opportunity for outcomes measurement that are objective, measurable outcomes. And there's also an opportunity for patient-reported outcomes focused on things that matter to patients. Like, instead of saying that this patient didn't have any complications from their orthopedic surgery, didn't require a transfusion, didn't get an infection, let's ask the question that matters the most to the patient was, how quickly was this patient able to get back to work? What was their return to function like? How was their experience and et cetera? Those are sort of the outcome measures that matter most to patients. The other thing that's, I think, a challenge sometimes is that many of the specialties don't have as many clear, focused outcome measures. There's an organization called ICHOM, which I'll mention, that can help guide people a little bit. It's the International Consortium of Health Outcome Measurement. And they've spent the last 10 years defining by specialty the certain measurements that are standardized measurements by specialty that can be embedded into value-based contracts and help incent performance. So if you're looking for a place to find some measures, ICHOM is a good place to look as well.
I think I would piggyback off what Adam said, because patient-reported outcomes are, in my opinion, and I don't want to overstate this, but I think that's really the key to how we are going to measure value in the future, right? Another organization, which everybody knows, is the NIH, has compiled what they call their PROMIS measures. So patient-reported outcome measurement information system, something like that. But you can search NIH PROMIS. And these are all standardized tests that are computer adapted tests, right? So it takes you about 4 or 5 questions to arrive at a number. And it's a numerical score, 1 to 100. 50 is always the population norm. And so in 10 is the standard deviation. So if a patient comes in to my office and they have a pain interference score of, let's say, 61, well, they're 1 standard deviation worse pain interference than the general population norm. And if alternatively they come in and they're a 50 and they say, well, I got this x-ray and somebody told me I had arthritis, what should I do? It's a pretty easy answer. You can say, you don't need to do anything. You just have arthritis. We're not going to operate on your x-ray. We're going to operate on you as a patient. And so having more of these types of things embedded in the work we do is going to be super helpful. I guess we can wait at the, I'm reading through the chat here and there's so many questions I want to respond to, but Krista, go ahead. I don't know if you have any thoughts on the outcome measure.
Yeah, I would just add, I don't think it can be overstated enough that we have to come to agreement around how we're going to measure quality. We have hundreds of measures on the plan side, right? When we talk about quality, plus hospitals have different sets and it's different for every, we can't possibly focus on that many. So I think we have to decide what's really important. And I 100% agree. It really should be on patient assessed outcome, because that's ultimately what matters. How functional are they? How do they feel about their experience? The other thing I just wanted to add here is we talk about, risk and the movement of risk from entity, that I think is important is your average provider organization doesn't know how to manage risk. That's not an innate skill that they have. Plans have been doing it, health plans have been doing it since they were created. So plans have a much better understanding of how to do it. And so, as you start to talk about these arrangements, it's really important that the plan has to kind of sometimes lead the provider along and help them gain an understanding. If you just come up with a risk-based contract and you throw it over the fence at a provider, they're going to fail because they just won't know how to do it. So there's got to be a lot of hand holding. You have to have the right size population so that it's big enough so that you can spread the risk. You have to think about true risk adjustment mechanisms. You should get paid more if you have a sicker or riskier population. So there's all kinds of, I think, technical components that we don't have time to talk about, but I think are really important when you're talking about movement of risk, and that have to be worked through between the partners, so that you ultimately get kind of the long-term outcomes that you want.
As we dip our toe into value-based care at UW-CPED, those are discussions that we want to get deeper in the weeds on, in future offerings for sure, because the devil's in the details, right? But I want to just make a quick distinction, and then we can go to the Q&A if you'd like. But I see in the chat the question about patient satisfaction. Patient satisfaction is wonderful, but patient-reported outcomes is not necessarily patient satisfaction. And let's make that distinction, right? Because I could come in and be drug seeking, wanting more narcotics, and give the provider a 1 out of 10 when they say, I'm not going to give you a prescription for narcotics. I'm going to, in fact, send you to PT and do an injection, and that actually will help you, right? So patient satisfaction, I think, needs to be distinct from the concept of patient-reported outcomes. It's very, very different.
Great. So I think now's a great time to turn to the Q&A. Jason, it sounded like there was a question you wanted to answer.
I'm sure all of them, but yeah.
So we'll leave the triaging to the surgeon.
Exactly. Yeah. Well, you guys pick, or Mark, why don't you lead the questions? Because
I'll call it a few.
Yeah, go ahead, Dan.
One question we got is, you might be worried that complex patients, underprivileged patients, medically needy patients might be at a disadvantage in this kind of system, that providers might be compensated less for them, or they might not be able to sort of navigate it as easily. So what types of safeguards would you recommend building to prevent those difficulties?
Yeah, one of the ways I think that can be done effectively is to simply report. One of them is transparency, and to parse your outcomes for the population that you're caring for by race and ethnicity. I think often we pool all outcomes together for the populations that we serve, and we don't know of the disparities. And I think if you just simply start to look at even what are the outcomes like inside of our 4 walls when we have someone hospitalized, if you break it down, you'll find that there are disparate outcomes inside the 4 walls where you're able to control most of the variables. Why is that? And you're not going to know that, you're not going to pay attention to that unless, and you're not going to then address that unless you have the transparency associated with, those outcomes by people group. And so I think it really starts with that.
Yeah, I agree. And then I would circle back to the comment I made about risk adjustment, right? So patients that are more complex, do truly require more care to manage effectively. There needs to be a mechanism for making sure that enough dollars are provided to care for them adequately. And that's where I think risk adjustment can come in as well, and make sure that you're not undercompensating or somehow creating an environment where your provider system doesn't want to see folks that actually they really need to be seeing, because they end up upside down on them. So I think that's another important component.
A couple of the questions here are sort of about the challenges with the transition to value-based care. So let me take both of them, I think. So one is that independent primary care providers for large populations of chronically ill patients feel fatigue and burden, but they have fewer resources. It can be harder for them maybe to manage things in the health system. So maybe you could speak to how primary care physicians in general and independent ones in particular sort of fit into this ecosystem.
Yeah,
Adam should answer. Adam should
Go
answer
ahead.
that. Yeah, no, Adam should answer that, but you hit the one that I wanted to comment on, and I just say that Adam can provide the primary care backdrop, but I too am coming to this as an independent provider in an independent practice, and so I would just suggest that, per Krista's point, there's ways to negotiate value-based contracts with payers whereby as an independent practice, you're very able to be nimble enough to execute on what needs to happen in those value-based contracts. But please utilize a content expert on that instead of saying, oh yeah, that looks good, great, we'll just agree to that. There's a lot of nuance to those contracts.
Completely agree with all that. I'll just say, one, if you think about it, the reimbursement to, as far as the share of the healthcare dollar that goes to primary care physicians, I personally think it's just not large enough, period. I mean, they get, depending on where you look and what the overall dollar is, about 6, maybe 7% of the healthcare spend goes toward primary care. And they're actually providing at least double of that percentage of the actual care. And if you think about, the behavioral health crisis we have in the U.S. right now, the number one provider of behavioral health support in the U.S. is primary care. And they are, not necessarily supported or equipped to do so, but that's just the reality. So I think one thing that needs to happen is just a larger share of the healthcare wallet can be directed toward primary care, period. The other thing that I think can happen is that, and this is a negotiation point for primary care groups with payers, is to ask for care management fees up front. It's a certain set of upfront dollars that can help you resource yourself well enough to do some of these things. And then the other thing that can happen is independent primary care providers and groups can stay independent, but yet align with each other through things called clinically integrated networks that can do a couple of things. A clinically integrated network can essentially help provide more power in the negotiation process for clinicians, but they can also pool some of their resources to help bring to bear some of the care management resources or the additional support that needs to be there in order to be successful in a value-based arrangement. So I think it's total share of wallet, some upfront dollars in care management fees, but then also think of things like clinically integrated networks that you can align with each other in order to help empower that.
Yeah, the other thing I would just add here is that pick your partners carefully, because I think any size entity with the right partner could be effective, but you have to have a partner that's willing to sort of start with you. If you're at 0, that's where you should start. You can't have a partner that wants to start you out at 5, and then again nobody wins, because it's, the plan might get a big windfall, right? And you might, have some serious financial consequences. That's not a long-term success story. So I think you can find a partner that'll work with you, where you're at and where you want to go, and leverage the strengths that you have, and then supplement. Because I know even in our global cap arrangement, we still do a lot of care management on behalf of our provider system, because it's a strength that we have that they did not. So, understand how you can work together most effectively with that partner.
think
I think
probably
these answers. Oh, go ahead, Jason.
no, I mean, I just think probably the biggest takeaway, because this is a segue to Mark now. The biggest takeaway is from this discussion is there's so much more to unpack with value-based care. And this was not intended to be an all-inclusive webinar where you would leave with a degree in how the value-based care system should unfold in America. But I think it's encouraging to hear all these questions and all the questions. I'm just paging through the Q&As and stuff, and these are all really important questions that I think deserve to be unpacked, with far more detail, and certainly to all of those in the audience that, this is a goal of the project that we're trying to do here with UWC-PED.
Let me take one more question that I'm personally very curious about, which is, like, a lot of what you describe is sort of developing care pathways or following the evidence, doing what's right for patients. But I imagine that it's not always obvious kind of what works for your patients, or how you should be handling them, how you should be organizing things internally. So, does this transition require kind of experimentation and relearning in organizations? How does that process look?
Yeah, I would say you'll never get it right the first time. And everybody needs to be prepared, right? So I think it's setting it up more like a cycle of, this is what we're going to try. Here's how we're going to measure it. Right. Here's our path for how we're going to manage through this. And then here's how we're going to iterate. We're going to learn from what didn't work, and we're going to iterate the next time, and we're going to try the next thing. I think you have to come in, because even for somebody that's sophisticated, I mean, how healthcare works has changed, right? What was, best practice 5 years ago is different now. The technology changes. And so even if you were perfect on day one, at some point you're not going to be right anymore, because science keeps us moving forward. So I do think that's got to be embedded in the process, is you have to have some kind of ongoing review of effectiveness and how you're going to, iterate going forward.
I completely agree. I think a Deming's PDSA cycle, on steroids, just create a virtuous cycle of learning, where you evaluate and you set those measures out up front and just iterate.
Great. Well, I think that's a great note for us to end on.
Yeah. Thank you, Dan and Krista and Jason and Adam. And thanks everyone for attending today's webinar. And before we end, I just wanted to remind you that CPED is here as a partner, and will continue to offer thought leadership like today's webinar. And to Jason's point, this topic is very important to all the questions that we've had, of course. So it's a topic we're going to continue to dig into and offer resources and potentially workshops around. So stay tuned for all of that. My email is on this page. Please feel free to reach out. I'd love to talk about your organizations and how we might be able to assist you. And again, thank you all. Thank you, panelists. And I look forward to the chance to potentially meet and partner further with some of you. And thanks for your time today. Have a great day.